Hi there. I'm Dr. Rosenthal. Dr. Shulman is right in front. And these are our disclosures. I just wanted to say I've never actually spoken for anybody before, ever, because I kind of feel like you can't be trusted. That's how I feel. But I've known this company for so long. I've known Iris from forever. And we have used Iris lasers and now Iridex lasers at New York Eye and Ear for so many years. It's just a great company, and I think this is a great thing, and I don't mind talking about it. So there you are. How I got interested in MicroPulse is probably the reason that a lot of you are interested in MicroPulse. I've been interested in treating diabetic macular edema since I was a resident, which I'm dating myself, but since the early 80s. And it's been a frustrating journey. Treating DME with continuous wave laser, as you know, it works sometimes, not in other times, and it leaves a lot of damage behind. Can everybody hear me? You're all okay? We started out by targeting microaneurysms. We're treating all the red stuff. And we thought they were the cause of the fluid in the macula. And then we tried grid treatments, and then we tried subthreshold grids, and then we tried intravitreous injections. And all of this, I think, was without really a clear understanding of what we were doing, but that was the state of what we had. Sometime in the 80s, I think, Bert Glaser did some seminal work. I heard him speak about how laser works by causing a hyperplastic scar of the RPE, and that elicits factors to go into the retina that reduce the inflammation and the edema, and it suppresses neovascularization. But the key was that you had to produce RPE hyperplasia in order to achieve those things. You had to produce a hypertrophic scar, and otherwise you didn't get this stuff produced. So many of us ended up with a lot of patients, you've seen them, with way too much pigment in the macula, and they get pigment creep and poor vision. And there was nothing we could do about it because we didn't have anything better. But that's why a lot of us have shied away from doing focal laser treatment with ordinary laser. It just doesn't help. We didn't have OCTs. Sometimes it worked. Even with the grid treatments, it was difficult to treat large areas of edema in the macula, as you know, and certainly you had to stay away from the fovea, which was my biggest problem. So if the edema was central, you had very limited options. You couldn't treat the center, so what do? A lot of us have had kind of mixed reaction to the intravitreal drugs. You have to keep doing them. A lot of times you have to do them every month for forever, and the patients get a little tired of that. The treatment burden is huge. So most of us have been kind of waiting for the next great treatment to come. We've been waiting for the breakthrough. When I heard about this, it was like, duh. One of the problems that I had with regular laser, focal laser, in the macula was, where on earth do you treat? You have to stay away from the fovea. Where is the fovea? When the macula is all edematous, you can't even find it. What do you do if the patient is moving around, which, you know, I work in the clinic at New York Eye and Ear one day a week. The patients are, oh yeah, I'm holding still. Forget it. And how do you teach residents to treat patients like that? Your heart's in your mouth when they're treating the macula, and they're good residents. Our residents are top residents, but how do you train people when the patient's moving around and you have to go close but not too close? Horrible. Here are some examples. These are old slides of mine, but this is an example of where on earth do you treat? Where are the landmarks? It's not like you have the fluorescein superimposed on this picture. Where's the fovea? Maybe it's somewhere over here. I don't know. These fine, hard exudates, I think this whole area is swollen. So what are you going to do? Here's another one. Well, the swelling is right here, and that's probably where the fovea is. So where are you going to treat? you can't, I mean, treating out here is probably not going to make those exudates go away. What do? Here's another one. I think the fovea is somewhere in here. I mean, can you find it? I can't. Here's an angiogram. I mean, look at where the leakage is. And I think the fovea is right in here. I think that's the capillary free zone. So where are you going to put laser treatment? It's really close in. And you're going to get hypertrophic scars so close, and they're going to creep. I don't think it's good. Here's another one. You have this huge circinate ring, and I think the fovea is right there, and it's probably a little elevated. This is a huge area to treat with continuous wave laser. You're going to have big areas of poorly seeing retina after that. Here's another one. Where on earth is the center of the fovea? Is it here? What are you going to do? Where are you going to treat this patient? You're not going to just treat this and this and this. We know that doesn't work, right? So the great thing about MicroPulse is that you can treat very large areas of the macula without any injury to the macula. You can even treat right across the fovea if you have to, but you don't have to. If the areas of edema don't go into the fovea, you don't have to treat the fovea. But if you need to, you can. And if you know, some of this is, you may not want to treat the fovea, but you may end up treating the fovea because the landmarks are very obscured. So, but if you inadvertently do, it doesn't matter. It's not going to hurt the patient. To me, this is the greatest thing since sliced bread. So how does it work? Well, basically, MicroPulse takes a pulse of energy. When you use continuous wave, let's assume that this is like 1/10 of a second. The laser is on, and then it's off. It's on for the entire 1/10 of a second here. The whole time that you step down on the pedal, the laser's on. When you have MicroPulse, you still have your 1/10 of a second that you're treating, but when you're treating, you're only treating for certain intervals. The laser goes on and off by itself with whatever duty cycle you choose. Most of us choose a 5% duty cycle, so that means that the laser is actually off 95% of the time. So it's pulse, 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 pulse for that 1/10 of a second. So you don't have the same exposure to the laser energy, and you get a much smaller dead zone with the MicroPulse. It just gives you much better control of how much energy is actually getting to the retina and the RPE. And it still stimulates all the same kind of factors that you do with continuous wave laser. You get the same kind of effect. You get it in a slower kind of period of time. It takes longer to have an effect. You have to wait longer to see the effect, but it's much more controlled. There have been a bunch of clinical studies that have shown that this is safe, that have shown that it works. I was frankly appalled that I wasn't more aware of this until last year. I was like, where have I been? But there are a lot of papers that have been published. There have also been a lot of studies that have shown that MicroPulse truly doesn't injure the retina, that when you do microperimetry, it actually improves after MicroPulse therapy, which is really what we all want, but we don't get. And this is why, when you use MicroPulse, here you're using continuous wave laser, you have a lot of dead spots, a lot of areas where you're really injuring the retina. And if you turn the power down, you're still getting areas where the retina is dying. You get smaller ones, but you're still getting areas where it's dying. And if you space it out, you're still getting areas where the retina is dying. But if you use MicroPulse, you can actually go low intensity and high density. You can actually use confluent burns, and you're not going to get any injury to the retina. So Julia's going to come and show you some cases that she has done, and we'll take it from there. I don't know if you need the pointer, it's right there.
Oh, hold on. So here are a couple of recent people that I've treated with the MicroPulse. This is kind of a mild to moderate DME patient, and 2 months out, you can already start seeing the improvement in the swelling on the OCT. Just another slide kind of showing you the diffuse leakage on angiography and the improvement 1 month post MicroPulse laser in another eye. This is a great case, and I've used this for CSR, and I've seen a pretty good success. This was a patient who had seen like 4 or 5 other retina specialists and has had subretinal fluid for over 6 months, but he was told that he was going to get a bad scar if he was treated in the central vision, so he was worried, and his visual acuity was pretty good, but clearly he was symptomatic. So what I did is I actually just did 1 grid over the hotspot, which was here, 1 confluent 7x7 grid, and I'll show you the parameters in a little bit. And this is 10 weeks post MicroPulse. So I did not treat diffusely, just in that 1 area. And here's another DME patient, 2050 with diffuse leakage, and you can see the improvement in the retinal thickening and edema 23 weeks post MicroPulse. So this is what it looks like when you're looking through the microscope. It's actually a little delayed on the video. It goes a lot faster in real life, and you can see the grid and you see the dot kind of making its way in the grid. And the typical treatment protocol that we use is a 7x7 confluent grid, so you take the spacing away completely, and it's a 200 micron spot size, 200 millisecond duration, and 400 milliwatts, so it's a pretty hot intensity, and then of course the 5% duty cycle, which is what the MicroPulse is all about. And literally, other than for CSR, where I really just treat over the hotspot, you can apply confluent patterns over the areas of thickening in DME, and as we mentioned, you can come close to the fovea or treat over the fovea. We talked about the confluent high density application. You can really kind of see what you're doing with the grid and target diffusely the areas of thickening. It's a very consistent laser delivery system. I find that it's very efficient, and in general, this device, this laser, we've purchased it for our practice. It's the only laser we have. It does everything. You can use it with continuous wave for PRP and demarcations, tears, and then you also have the benefit of the MicroPulse, for the macula work.
So people often ask me, they say, do you really treat across the fovea? And the answer is, yeah, I do. And I started doing patients that had failed everything else. I'd given them a bunch of shots and they weren't any better, and we had tried observation and we had tried this and that, and nothing works. So I felt pretty good about offering them this because we didn't have anywhere to go other than just to leave them alone. So, I think tight hyaloid patients, yeah, obviously you want to pull the hyaloid off, but in patients who have tried everything else and they're not getting any better, they've got nothing to lose. This at least is safe. I felt that I was not hurting them, and some of them have done better. Now, bear in mind, I've done pretty bad cases, because I've only done the cases that are not working. I'm getting more and more bold about using it on mild cases, and cases where they haven't had anything else, because I've seen it work, and then they don't need injections every month. You want to talk about this?
Yeah, just practice-wise, the considerations of why we decided to pick this laser for our practice is, like I said, it's a workhorse. It does everything, plus you have the MicroPulse option. So we thought, why not be able to offer that to our patients? In general, I feel like it's a great tool for people who have swelling but excellent visual acuity, and you don't necessarily want to treat those 20/20 eyes with monthly injections, but you want to treat them. They have uncontrolled diabetes. You know that swelling is going to get worse. So it plays that role in my practice for sure. And I'm not worried about scarring. I'm not worried that 10 years from treatment, they're going to come back with massive macular scars that have crept and visual deficits secondary to the laser as opposed to their diabetes. There's certainly studies that have shown efficacy and validated MicroPulse. It's efficient, it's a laser, it sits in a lane in our office, and when you don't want to use the MicroPulse, you just push a button, MicroPulse off, and you're doing your PRPs. We have the textile, so you still have the grid pattern. You don't have to do the old school pushing the pedal or repeat PRP, so that's nice. Economically, I think that it's a nice adjunct, again, for patients who are requiring a lot of injections and, you want to use laser, or who are not responding, or who have excellent visual acuity and you want to treat them, with focal. In the past, you would have treated them with continuous wave focal, but now you have this other option that's gentler, and it can certainly be titrated just like conventional focal laser. And I think the economics, it's just an excellent adjunct in our practice, and we've really enjoyed having it. So you really don't see tissue damage on your exams or OCT after treating these patients with laser. And of course the response is going to be slower than pharmacotherapy, just as it was with continuous wave focal, but again, it's not disruptive to the tissue. And usually after I treat people, especially diabetics, you watch them, and I wait 3 months before truly assessing the response to treatment, just as I did with continuous wave focal before. Of course, there's really no discomfort. Patients don't feel it. And it's being used and studied for a lot of other applications like CSR, I already mentioned. I'm already doing that in my practice, but even things like Macula, radiation retinopathy, they're ongoing studies to look at that. In fact, I think there was a paper in Retina recently, the small cohort of CSR patients that had MicroPulse that reported really favorable results. And early treatment of mild edema, I have a lot of patients in my practice who, really have mild DME, but they have a hemoglobin A1C of 15, and I don't foresee them really getting it under control in the near future. And I'm much more likely to just treat them instead of waiting for that edema to creep into the fovea and lose visual acuity.
So basically that's it. I mean, we're ready to answer questions. In fact, I'll put my headset on.
Thank you very much.
Oh, yes.
Oh, sorry.
No, you got it. That's
yours
fine.
or mine?
That's yours.
Okay, thank you.
And I'll take this
We
one.
do have a couple questions that get their headsets on. And can you both hear me okay?
I think so, yeah.
I'm good.
You use the 400 watts for all people, all patients?
400? Yeah.
All patients?
Mm-hmm.
All pathology? ISR?
I don't change the settings.
Only?
I have it set 400, 200, 200. I never touch it.
How many times?
You mean how many grids? It depends on what I'm treating. So for central serous, I put 1 grid over where the hot spot, where the leakage is on angiography. Or if there are diffuse areas of leakage, I treat just the hot spots, not all the fluid. For DME, just confluent grids over areas of swelling. And I'm pretty generous because I'm not really worried about tissue destruction. You can exaggerate, but you can just treat the entire macula with confluent grids.
How many times you repeat treating?
I wait 3 months to assess the response, and I've had ones where I've repeated it, just like, with focal, or have done some combination. A lot of times, if they really have severe swelling, you may not wait, and then I'll be doing some combination of intravitreal injections and laser.
you show again the parameters you've used?
Yeah, yes. I think it's one more. Yeah, that's it. Yep.
They have really nice booklets
This
they
is,
can give you that has all this written down.
so it actually, you can preset the laser. So I have presets that I use, and this is my MicroPulse preset. And so I actually never change the spot size anymore at all, because I use 200 for PRPs and demarcations anyway. And so I just have it set to 200, and then I will click my MicroPulse preset, and it'll turn MicroPulse on, and it'll say MicroPulse on. And so you'd actually, I never change the spot size anymore.
I'm kind of old school, so I use a test spot, and I go either to the nasal side or I go far away from the fovea, and I do test spots and make sure I can't see anything, and then I go and I treat. But after a while, a lot of people stop even doing test spots. I mean, it makes me feel better that I've done a test spot, but
I think 400 is very sensitive.
But
it's dense, but it's micropulse. It's not the same thing. These are not the same. 400 and 400, it's not the same from continuous wave to micropulse. It's different. It's a whole different thing.
The market, 100 intensity, we mark it in the nasal 100, 200. No.
but because you're not delivering that energy continuously, you actually don't even see that spot. And when I first used it, and it was set to 400, being used to continuous wave, I was like, there's no way I'm putting that in the macula. I'm going to have a PRP pattern in the middle of the macula. But it's not, because it's burst.
Yes, I do. I use a test with the micropulse mode. I follow the protocol for using the test spot, using micropulse, and make sure I can't see anything. And then I go back and I do my treatment. You see nothing. You see no response. It's a little like the emperor's new clothing. You know, I mean, you'll see nothing. You should see absolutely nothing.
Eu put in micropulse in the nasal retina.
I do. I usually go nasal to the disc.
Don't
And
mark
also,
it, you
I let the patient get used to the
understand.
fact that they have the
Understand.
contact lens on, and I'm looking with. I just let them settle down a little bit, but you really probably don't have to.
If you do your test
I
spot
don't
without
have a free
MicroPulse,
now.
it's just a regular, that's going to be a very hot PRP spot then.
Just because then you can use a percentage of that, not exactly that.
As far as you treating microaneurysms, some doctors will like to go for it continuous wave first and then maybe then micropulse. Do you just micropulse over the whole microaneurysm or that whole adenomous area and not go after them individually? Or how would your treatment for a focal / grid, you go hit the microaneurysms first continuously and then micropulse, or
I don't hit the
over the whole area?
microaneurysms anymore. I just hit the areas of edema on the OCT, and I just treat that whole area. If it's across the fovea, it's across the fovea. Microaneurysms, whatever.
Yeah, I do not pre-treat the microaneurysms.
I think that whole thing of microaneurysms and treating them, actually singling out the microaneurysms, that's really been debunked. I don't think anybody really believes that that's better than anything else.
Dr. Shulman, on your CSR cases, what's your protocol to treat if you diagnose somebody with CSR today? Would you micropulse immediately, or do you wait a certain time before you micropulse, or on those CSR cases?
Obviously, the nature of the disease is that it will resolve in a lot.
Oh, sorry. It went.
In a lot of these
Yep,
cases, so
where'd
I
it go?
definitely don't treat right away. This patient came with a 6-month history of symptoms, and I still watched him for another 2 months before treating once.
And there are lots of people that I know that are treating CSR with micropulse. You know, sometimes you have CSR where the leakage point is very close to the fovea, and you wouldn't want to treat it with a continuous wave, but you have this nut job who really want to get rid of this. It's bothering me. I can't stand it. Normally, you wouldn't do anything. But now you have an option for those patients that's safe. I mean, most of us would still wait a little while, but if you're not getting anywhere and they're not getting better, you do have an option to treat, even if it's very close to the fovea. You can still treat that. Whereas continuous wave, most of us wouldn't.
Is there a central retinal thickness threshold before you use the micropulse? In other words,
You mean a number?
yeah, you know, say 450 microns.
Well, most of the time, we go by the appearance on the OCT, right? I mean, like that little cystic area there, I don't have a map, so I can't tell you exactly how thick it is.
Yeah, but do
But
you
it's-
give anti-VEGF first?
I don't, to be honest with you. The patient, what was the
Because-
patient's vision there?
I believe this one had really good vision. He was 20,
Yeah.
20, 30, 20,
Yeah, I'm
40.
not talking about these cases.
Yeah.
I'm talking about people with, 2200 vision, greater than 450 microns of central retinal thickness. I'm not really sure whether micropulse would work in those cases.
It does. I mean,
What, without anti-VEGF?
Yeah, without anti-VEGF.
And
Without anti-VEGF, it's certainly worth a try. I'm very much, I use vision even more than actual thickness. I use the vision. If the patient comes in and says, look, vision's going down, I'm noticing this, I'm having trouble driving, whatever, and I look in and they don't have a cataract or some other explanation and it looks like it's the macula, it's the macula. Well, then you have to decide how you're going to treat it. You could still pre-treat with Lucentis, Avastin, whatever, and see if it works. I mean, if you're more comfortable doing that, you certainly can. There's nothing wrong with that. But it's the risk of sticking a needle in the eye versus not sticking a needle in the eye and doing a treatment that doesn't have a downside risk. I mean, what happens is at first you're not comfortable and you'll end up doing your regular treatments and seeing if they don't work, then you may go to this and you'll become more comfortable with this. And after a while you're like, I really don't feel like putting a needle in this patient's eye. I'm going to just try MicroPulse. And after a while, you'll be doing a lot less injections.
What about for edema caused by CRVO and RVOs?
Well, I've used it. I can't say it's my first choice because I really think that injections probably are my first choice, especially in BRVOs. If you wait and they're not getting better, because I usually give them time to wait, at least a couple of weeks to see if the swelling's going to go down by itself. But I've seen this work. I've seen this work in patients who have gotten injections and they've gotten some improvement, but not enough. And you can certainly use this in combination with the injections.
All right, my experience with MicroPulse hasn't been that good. I've been using it now for about a year, and the edema does recur. I follow the same. I do a test spot and then vary the MicroPulse according to the response I get. And some of the patients, the edema has recurred back.
But how long does it take to recur?
Well, I do the MicroPulse, wait 6 weeks, do an OCT, and then I might repeat it again, repeat the MicroPulse again. And quite a few of them I've had to go back to anti-VEGF injections.
What I'm saying is, are you saying it goes away and then it comes back?
Well, I've treated CSR, it's gone away and it has come back.
Okay. Well, I think most people have seen that happen with the injections too. And with the injections, the burden is most of the time you have to keep repeating that. So it's the same kind of thing.
Sure. I thought this was the savior for those. But
Well, I think it's-
after a year of experience, I don't really think so.
To be honest with you, I think DME, if we're talking about DME, I think DME is really a couple of different diseases. If it was the same disease, then our treatment would work all the time on everybody, and we wouldn't have all these different
Also,
treatments.
you see, some of the patients I've treated have already had conventional laser,
Right?
and some of them have had a response.
Yes.
But I do not know whether the response now is as a result of the conventional laser I did previously, that the edema is settling down, or is it because of the micropulse?
Well, the way I try to straighten that out myself, because I have patients exactly like you said, is I do one kind of treatment, whatever it is, and I leave them alone. And if they're getting better, I let them go as far as they're going to go, as far as getting better, so they're stabilized, and then I decide whether I want to go further with some other treatment. But I like to let, if they had continuous wave laser, for example, I let them continue to get better until they've responded as much as they're going to respond. And then I decide what I'm going to do, because otherwise you don't know what's working. You do a couple of different treatments, you don't know how much is from this, how much is from that. It's impossible to parse that out.
And do you directly treat the hard exudates over the hard exudates?
I don't target them, I target the area of swelling.
Yeah, but you know, the hard exudate is usually associated with a lot of swelling anyway.
Yes, but there's usually
You
a
can't
lot of
avoid
other
them.
swelling.
Yeah.
And then I just treat over the whole thing. I don't deliberately not treat them.
Thank you.
You're welcome. Any other questions?
We're using Mactel.
I have not used it for Mactel.
No use?
No, but it's
No.
being studied for that application. I don't know. Have
Use-
you?
I haven't
No,
used it.
no. It's
I have
possible.
I have a couple of patients for whom I might actually try it. I mean, you know, Mactel is very hard to treat. Basically, nothing works,
Not.
and nothing really works. And
I know an earlier presentation yesterday, there's a physician who uses it for that, and this afternoon, Dr. Sam Mansour has experience successfully using MicroPulse.
yeah, I
for
would listen
Mactel.
to him. I would listen to
If
what
you're
he says,
available.
because he's really got a lot of experience.
I had one patient with Mactel, I used it. Nothing else worked for her. And her edema actually decreased after the first treatment.
Okay.
But it has now recurred. I only saw her last week.
The parameters?
Maybe treat her again. Mactel is a weird disease. I don't even think we know exactly what the cause of it is, and if it got better using MicroPulse and the effect lasted maybe 3 to 6 months, and then it recurred, I would treat her again. If that's the only thing that had any effect at all, I would retreat her.
Well, I saw her last week. Her vision actually did improve a little bit. It was count fingers before, and now it's about 660.
Yeah.
So she was a bit disappointed.
Well, part of the problem is I think she sounds like she had a really bad case. Her vision was already terrible.
Oh, it was,
So
it
it's-
was terrible. Yes.
You know, if you're treating earlier cases, I think everything works better
yeah,
when things are not so bad.
sure. It was.
But in these really extreme cases, I think it's difficult to get a response from anything. And even a little bit of response is probably pretty good.
What is the period of time that you're seeing the recurrence of edema after you initially treat? About 2 months. So we know we've had some physicians experience recurrence of edema in about 6 weeks, maybe a little bit more, but if they do nothing and still just wait, it does get reabsorbed.
I generally wait about 3 months to do another treatment. I see where they are at the end of 3 months, and if I'm not happy, I can always retreat. But I don't retreat prior to three months.
Yeah.
That's
Same
basi-
here. I always wait 3 months. I don't do any additional laser. I may do other treatments in the interim, but I don't repeat until 3 months. Well, anti-VEGF, or it depends on the case.
If you feel that MicroPulse is successful,
Well, in some cases it's not.
You do the MicroPulse. Do you see them before the 3 months?
Yes.
Oh, yes. Yeah.
So let's say I see them, say about 6 weeks after the MicroPulse.
Yes.
I do an OCT, and if the edema is worse, you're obliged to treat them.
If the edema is worse, frankly, I haven't seen that. I haven't had a case where the edema is worse 6 weeks after doing MicroPulse. I haven't seen that, but I think that combination therapy is not a bad thing. People are using combination drugs,
Sure.
so this is kind of analogous. And to say that I never inject anybody anymore, I always just do MicroPulse, that's not true. That's not true at all.
The point with combination therapy is you really do not know now which one is working.
That's exactly right.
It is the anti-VEGF,
That's exactly right.
or the MicroPulse.
Or it's a little bit of both. We don't know, and it's the same with using two meds. We don't know whether we're treating some part of the pathology with one medicine and some part of the pathology with another medicine. Nobody really knows. If you've been to the retina section from yesterday and the day prior, there were all these papers. Basically, nobody knows. Nobody has any idea. That's why they're presenting like 6 different medicines. Nobody knows which is better, and nobody knows whether you should do this one first and then this one second, and maybe it's the two of them. Nobody knows. These have not been elucidated yet. And every case, I think you have to use your own judgment. Any other questions?
Okay.
Everybody
Any
okay?
other questions, comments? But we can continue this also after we
Okay.
after we turn the microphone off. Thank you all
My
for being
Portuguese
here.
is really bad.